Good morning, all of you. I officially open the Virtual Patient Perspective Roundtable, Patient Advocacy and Support in the Backdrop of COVID-19. I would like to congratulate IGCS for this fantastic initiative that I'm sure will be very profitable for all of us. My name is Maurício Magalhães Costa. I'm the today moderators. I'm a IGCS council member. I am a president of Sinological International Society. I'm a breast surgeon, a gynecological oncologist, member of the National Academy of Medicine, and I really welcome to this June session. The next slide, please. I welcome to the June session of the Patient Perspective Roundtable series, an IGCS initiative developed to facilitate the continual exchanging of essential information in this ever-changing environment of the COVID-19 pandemic. The series is a significant component of IGCS effort to contribute to the global needs for vetted, constructive, region, and population-specific information and guidance. Survivor, patients, and family members are constantly searching for reliable information from trusted sources and from support services as well. Important among this source of international and support are patient advocacy organizations, such as the three features in today's sessions. This virtual roundtable series brings together various stakeholders, communities within the safe distance confines of a web seminar. We plan to host a monthly virtual roundtable, each one on different topic important to the survivor patient community, to clinician research community, and to the industry. This session, titled Patient Advocacy and Support in the Backdrop of COVID-19, will feature 5 panelists covering different populations, regions, gynecological cancer sites, and other perspectives. We are thrilled to have attendees for over 40 countries joining us in this session. Next, please. This is our agenda, the opening. These are the groups that will participate: ECANA, Endometrial Cancer, Primary Specific Emphasis in African American Women. The group, the another stakeholders share: Ovarian Cancer, Primary Breast Cancer, and Uterine Cancer across population surveys. Women4Cancer, Early Detection and Treatment, Cervical Cancer, Primary and Kenyan women, with limited coverage of other countries and regions in Africa as appropriate. After this 5 presentation, we'll have question and answers and the closing remarks and take-home message. Please, next. This is my background, Maurício. Next. These are our panelists from the ECANA, Kemi M, that's project lead of ECANA, gynecological oncologist from the University of Washington, USA. Margie Willis, advocate from ECANA, endometrial cancer survivor, USA. Please, next. From the Shared Cancer Support, Breast, Ovarian, and Uterine, Silverman from the Uterine Cancer Program, coordinator of SHARE, USA. And Nefa-Tari Moore, Uterine Cancer Program, Associate Helpline Coordinator, Support Group Facilitator of SHARE, Ovarian, and Uterine Cancer Survivor, USA. Next, please. And the last, Women4Cancer, Early Detection Treatment, Benda, Kithaka, that's co-founder, chair, Women4Cancer, Early Detection Treatment, Kenya. We have 5 outstanding presenters and speakers, and I am sure it will be fantastic. I will, in the next minute, show just an update of the situation of COVID-19 in the world. Is well known for all of you. Unfortunately, it's a nightmare for all of us. A very tragic situation that is ongoing, and we don't have any perspective of the end, only the vaccines, but we are not, we don't know exactly when it happens. These are the numbers. We know it starts from China, from the East, but came to Europe, and now is very strong in America, especially in the United States and in Brazil. In Latin America, Brazil is the biggest. Next, please. If you analyze the number of deaths according to the continents, you see Asia and China, that was the beginning. They have a very strict control. They really control very well the widespread, but unfortunately in Europe we had a huge number. North America, that's still growing. Europe is under control, at least under control, but in Europe, in North America, especially United States, is growing very fast. And in South America, that's also growing too much. We are still in an exponential curve. We're not flat yet. And Africa, we don't know about the numbers, if there is some sub-notification, but the numbers are not so high. And Oceania, that was very well controlled in Australia and New Zealand. Next. And the data in Latin America, these are the numbers. In all Latin America, we have 100,000 cases, and deaths was 2.5 million cases, and it's half of them are concentrated in Brazil. And in this moment, it starts in São Paulo and Rio, that are the two biggest cities in southeast of the country, where we have more tourism, but now is widespread in all the country. But fortunately, there is a good control in the frontiers, the borders, and we don't have many cases in all the other countries. Next, please. And it's very important from the beginning that all the medical institutions, the medical society has established a lot of recommendations for the treatment of gynecological breast cancers in the COVID-19 pandemic. The USA Centers of Disease Control and Prevention and the American College of Surgeons recommendations to postpone surgery if possible, or consider performing the procedure as an ambulatory surgery center. It's obvious that we should minimize utilization of medical resources and supplies for non-urgent procedures. This approach helps us to maintain reserves that may need to care for COVID-19 affected patients, include personal protective equipment, ICU beds, cleaning supplies, and ventilators. We should also keep in mind that every hospital visit expose patients and healthcare providers to the risk of contracting COVID-19. Next. The American College of Surgeons has issued a statement and distributed to the members that each hospital, health system, and surgeons should fully review all scheduled elective procedures with a plan to minimize, postpone, and cancel elective scheduled operations, endoscopy, and other invasive procedures until we have passed the predicted point in the exposure graph and can be confident that our healthcare structure and support a potentially rapid and overwhelming uptick in critical patient care needs. Next. Although medical centers must continue to offer care that cannot be postponed for months for some non-COVID-19 related condition, example cancer, the benefits of this care should be balanced against the risk of COVID-19 exposure for patients and staff during this pandemic. Next. But another point that's very important is that COVID-19 and cancer they are related, not only as cancer is a risk factor for the patient, as the COVID is delaying the treatment of cancer. An international study, the impact of COVID-19 on cancer patients, has found an alarming trend. The death rate is more than twice that of other people who contract the virus, leaving doctors searching for answers on how to continue care. This study, which had earlier described in the Lancet in late May, looked at people with both disease in the US, Spain, and Canada. It concluded that cancer patients were much more likely to die from COVID-19 than people without cancer who got the virus. As elective surgery and treatment resumed, doctors and patients are wrestling with the risk of delaying treatment, further versus the risk of exposing cancer patients to COVID in a hospital setting. Next, please. Then I think for the discussion that we have now with the panelists, it's very important to consider these points. The risk of COVID-19. We know that not all the women, not all the patients with COVID will die. We know that 80% will have very soft symptoms. 15% will have more severe, but they can be treated without very strong treatment. But about 5% will really need intensive, severe disease, intensive care. And these are especially elderly, cancer, diabetes, cardiovascular disease, and obese patients. These are situations that we know that increase the risk for bad outcomes in this patient. And there is also the risk of gynecological cancer. We know, we used to say that cancer has no quarantine. They are not waiting, the disease will progress. Then we cannot lose time. We know as early diagnosis, early treatment, better outcomes. And the risk of gynecological we should consider in this situation. Another point is social isolation lockdown. In countries like Brazil, it's very difficult because we know 50% of our population lives in a very bad, in a social low income and in informal work. They need to work. They need to go to the street. They need to work. And then to just ask them to stay at home, leaving a lot of people in the same residence is very hard. And of course, is not effective as a control. And there's also a big problem that you have a socioeconomic situation that is very bad for the whole world, but especially in countries like Brazil, in low and middle income countries in Latin America, this situation is getting worse. And we, beside the sanitary problems, we'll have many socio-economical problems. Well, I think with these points, the next slide, please. I will invite our panelists to make the presentations, especially the first from ECANA, Kemi M. You could start your presentation. And thank you very much. And after all the 5 panelists, we'll come back for the question and answers. Thank you very much.
Thank you so much for that introduction. My name is Kemi M, and I am co-founder and project lead for ECANA. And I'll be co-presenting today alongside another co-founder, Margie Willis, who is an ECANA steering group member and endometrial cancer survivor. So ECANA stands for the Endometrial Cancer Action Network for African Americans. We're a group of women who've come together to create support community empowerment for any African American woman affected by endometrial cancer. We are a multi-stakeholder group by design, so we have clinicians, researchers, as well as patient survivors and community leaders in our group, all really committed to improving early detection and ensuring that Black women in the United States who are diagnosed with endometrial cancer not only survive, but also thrive. I'll spend a little bit of time talking about us and then our response to COVID-19. This is us, our steering group. We're very patient-centered, so though we're multi-stakeholder, the majority of the folks on the steering group are patient survivors, and you can see our values there of transparency, trustworthiness, co-learning, and importantly for this presentation, really trying to be solutions-focused. As Black women in the U.S. dealing with endometrial cancer, there are a lot of barriers and challenges considering all of those things layered on, and we try very much to be solutions-focused in a positive group, bringing about positive change. Next slide. In terms of activities, we have many. And on our website, we have multiple videos and stories for patients to be able to connect with people who look like them. Our Survivor Sanctuary program is something that we'll talk about later on in this presentation in response to COVID-19. There's also a lot of education on the website, again, trying to increase awareness of early detection symptoms as well as treatment for Black women, and a peer education program that I'll speak about shortly. One thing we won't focus on in the presentation today is our research activity in also being able to be voices at the research table for the kind of new scientific discoveries that will improve the outcomes for Black women with this disease as well. Next slide. This is the larger group. So we're made up of a steering group, but also national ECANA ambassadors, of which there are currently 13 in 11 of the US states around the country. Next slide. So we gathered for a conference, and this is just to give you a little bit of background where we covered many topics over 2 days in 2019, not only learning about endometrial cancer, but also doing training around peer education so our members could go out and facilitate trainings among their community about endometrial cancer and early detection. And in doing so, essentially become points of expertise in their own communities about what's going on with endometrial cancer among Black women. We really found that the survivors were, as much as they wanted to connect and create community among each other, there was a strong desire to give back to the community, and that's really where a lot of our activity is focused. Next slide. Our peer education program is called Community Empowerment Partners, and it aims to increase knowledge, empowerment, and improve health outcomes in the Black community. We trained ambassadors in 11, that represented 11 states in the country. And essentially, they all held sessions in their homes, in churches, in libraries, in their communities, talking about the signs and symptoms of endometrial cancer and of menopause. This was a multi-layered intervention because in addition to increasing simply education and awareness around endometrial cancer in this community, we also started to begin to create bonds around talking about these kinds of symptoms that are often silenced, as well as, again, promoting our ECANA ambassadors as experts in their own communities. And these are just some pictures of some of those gatherings that happened all over last year, which was our flagship program last year. Next slide. Again, we're involved in research as well, including having a member on the NRG Uterine Cancer Committee. I'd like to come back, however, to community building. And this is really, this has to do with COVID-19 because of the fact that we've been spread out from the beginning with ECANA. We've always been a national organization all over the United States. Virtual connection and social media outreach and all of that has been the feature of our organization. So we do a lot of social media outreach in terms of web messaging about symptoms and self-care and support. We also do send educational hard copy materials to clinics that are culturally relevant to Black women and featuring Black women surviving and thriving. And then we have the website where survivors can contact us directly to be placed in contact with another Black woman survivor for support during their journey, and the sanctuary that we'll speak about in a moment. Next slide. So with regard to COVID-19, as was discussed earlier on, in the United States, the Black and Latinx communities have been hit the hardest by COVID-19 by all measures, with more infections and more deaths. There's just two very quick statistics here from New York City and from Louisiana that just demonstrate the outsized mortality among the Black population who are infected with this disease. And as we've heard before, cancer on top of that is yet another risk factor. We see these statistics in the personal lives of our ECANA members. We've had members directly affected by COVID-19. We've had members living with family members who are affected and hospitalized for COVID-19. We have not had any of our direct members succumb to COVID-19. However, certainly within our small networks have unfortunately had friends and other endometrial cancer connections pass away from this disease. So it's very real as an organization focused on Black women that we are experiencing the statistics that are being shown. Next slide. So there were really minimal changes to ECANA's operations for COVID-19 because, again, we were already quite virtual in almost all of our activities. We did have some focused pivots, and that we shifted our social messaging to really support the evidence-based public health messaging around social distancing and staying at home. This was really important because, as was mentioned earlier, many in the Black community are in jobs where social distancing is quite difficult, where staying at home is not easy. We wanted to provide another voice on that message. And then we also shifted to more frequent outreach and contact through our ambassadors and among our steering group members for support. And it's through this that we developed the Survivor Sanctuary that Ms. Margie Willis will be speaking about, really in response to the need for wellness and positivity during this time where members were feeling quite stressed and really pessimistic about COVID-19 being layered on these other stressors. Next slide.
Hi, my name is Margie Willis, and I'm thankful to be here today. Thank you for inviting us. I am so excited to share with you about our Survivor Sanctuary. Number one, we want to be a support for women who are journeying through their stages of cancer. They've been a survivor for weeks, months, years. We want to be a place where they can come, talk, pray, release, vent, just be in an area and a place where it's safe. Ongoing relationships so that people can trust and know that we're there, know that we're genuine, and that we really want to be a support, has ECANA and supporting Black women. And the chair yoga class that we are doing right now, we've done 4 sessions. Our next one is July 10th. We started with deep breathing, we move, we stretch, everyone does whatever level you're at. And no matter what position your body might be in or what you might be going through, movement is always a plus. It's always a plus when we're moving. One participant that participated with this, when we were communicating later through email, she told me, she goes, I was doing an infusion the very first time I did this class with you. I said, what? Really? She goes, and it was just the best. And we've all just learned, we're able to share because we've all been through something very similar. While it's all different, it's still very similar. And the things that we get to share are so life-giving. And then to know that you have a place that you can come, someone that has ears to hear, someone who understands exactly, because in some way they went through some of the same things. And having that support and building that strong community of women who are just there for each other. So and we're just really new at this too. We just started in May, and I mentioned to one of our staff at ECANA that I had put some videos online, and then she's like, oh, and I said, oh God, sorry guys, I didn't send them to you, you know, and I just totally spaced. And she goes, hey, and then we just said, let's do it. And within a couple of weeks, we just jumped in, and it's been so great. We would love to meet you, come and join us. We'd love to get to know you and just to chat and to know that we are here for you. And as ECANA continues to evolve and grow and change and get better and better and meet more people, we're just totally excited and thrilled to be that helping hand and to be that support for women journeying through their cancer. Thank you so much for having us.
So in closing, our website is ecanawomen.org, and survivors can contact us directly through the webpage. And then our Survivor Sanctuary, which is chair yoga, movement, as well as conversation and connection, is every other Friday at the times listed there, and the registration link is also there. Thank you very much for having us. Thank you to the International Society for inviting us to be on this panel.
Thank you, Kemi and Margie. Our next panelists are Kitty Silverman and Nefa-Tari Moore from SHARE. Welcome.
Thank you very much. Hi, I'm Kitty Silverman. I'm the Uterine Cancer Program Coordinator from SHARE, and I want to thank the IGCS for inviting SHARE to participate in today's roundtable. I'd like to give you an overview of SHARE and then highlight some information about our response to the COVID-19 crisis. Our mission is to create and sustain a supportive community of women affected by breast, ovarian, or uterine cancer. Our aim is to connect these women with the unique support of survivors and peers, creating a community where no one has to face these cancers alone. Our peer support is really at the heart of what SHARE does. We train survivors of these diseases to facilitate support groups, answer helpline calls, and serve as peers to other women experiencing these cancers. And education and empowerment are also very key to our vision in 2 ways, both to raise awareness about the signs and symptoms of these diseases in the general public, and also to empower women who have been diagnosed with these cancers to make informed decisions about their care. Next slide, please. We have a wide range of services, which I just highlight some of them to you. This is an overview of what we do. All of our services are free. And while we're based in New York City, our reach is nationwide, and we have participants from all over the country. We reach over 200,000 people per year. We have peer support lines available 7 days a week, and a special Spanish helpline, as well as support is available in 26 languages. We have support groups that cover a range of different topics for each cancer community, interactive educational programs and webinars, outreach in underserved communities, workplace seminars. We also have online communities for each of the cancers that we serve. Next slide. One of the main focuses, special focus for SHARE, has always been serving the medically underserved communities. And for over 25 years, Latina Share has been providing a wide variety of services and materials in Spanish, and also has its own website and helpline. Share has been proud to be able to serve the Latina community in their own language in a way that is culturally sensitive to the needs of this community. The Ambassador Program reaches both communities of Latino and African descent and operates on the same principle. Over 30 trained ambassadors go out into minority communities, which have often been harder hit by these diseases, to share information about risks, signs, and symptoms. Next slide, please. I wanted to tell you a little bit more about our ovarian cancer program. We're excited. It's celebrating its 25th anniversary this year. And the program was first started by an ovarian cancer survivor who was looking for a support group. And her outreach prompted Share to recognize that there was a need in the ovarian cancer community for support. And we worked with her and several other volunteers to establish the program. We now have a wide range of ovarian cancer support groups, the helpline, 16 educational programs per year, education, as well as topic-driven roundtables, and a very active Health Unlocked online community with over 2,000 ovarian cancer peers. Next slide. In regard to COVID-19 and our response and programming, Share was really able to turn on a dime and quickly assess what our needs were going to be and how we could effectively provide our services to our communities. We began contingency planning in late February. All of our programs were transitioned to virtual or teleconference starting in mid-March and moved to the Zoom platform in April, and all the facilitators of the groups were trained on Zoom to be able to manage these groups. Recognizing the special impact that COVID-19 was having on cancer patients, we also developed special webinars as well as Facebook Live programs for gynecologic and breast cancers. And one of these was what the COVID-19 crisis means for gynecologic cancer patients, with two leading gynecologic oncologists in New York City who led that webinar. We also had our first blog post educating our community about coronavirus in early March with lots of guidance, information, and resources. We've had special newsletters and other material on our website. We've reached out through Facebook and other social media with a special ad campaign entitled "You Are Not Alone," where we've reached out to patients to tell them about the helplines for each of these cancers and to encourage them to reach out if they need support. We've also had virtual presentations in Spanish, additional outreach to that community as well, and are working on virtual outreach that the ambassadors are going to be doing in minority communities. Next, please.
Hi, everyone. My name is Nefa-Tari Moore, and I'm working with Share as the Uterine Cancer Program Associate, as well as an outreach coordinator. I'm also the helpline coordinator on the Uterine helpline, and as well as the support group facilitators for both the Women of African Descent support group and our general uterine cancer support group. And so today I'm going to tell a little bit about my story. I was first diagnosed with uterine cancer in November of 2013. I was having some heavy bleeding that was with some severe lower back pain. Those were my, symptoms. And I was weak, very weak one morning. I had a difficult time getting out of bed. I was working as a nurse. And that morning when I tried to get up, I just couldn't make it to work. And I would never, I wasn't known to call out to work. So even then I was kind of reluctant, but I had no choice but to. And I went to the emergency room. They hadn't diagnosed me at that point with uterine cancer, but I had a transvaginal ultrasound, and they could see that I was bleeding from somewhere, but they weren't really sure. But they referred me to an outside GYN who then wanted me to have a DNC, and it came back that I had uterine cancer. And my cancer went into remission for about 2 years, and I had a recurrence in 2015, and later on that year, April of 2015, and later on that year, I had a hysterectomy at the age of 35. And in 2018, which is how I, was introduced to SHARE, I was diagnosed with ovarian cancer. And I went through 6 rounds of chemo, and unlike when I was diagnosed with uterine cancer, I wasn't able to find any support then. So this time around, being diagnosed with ovarian cancer, I Googled and did some research on support groups, and that's how I came to SHARE. One of the members of the support group, which I still attend to this day. And when SHARE decided to add uterine cancer to their support, I just knew that I had to be a part of this program, being that it had affected myself and my family the way it did. And so now, as I told you earlier, we have this new program. It launched in May of this year. And what we have is, it includes helpline, support groups, patient education, and community outreach for those facing endometrial cancer and uterine sarcoma. We have our helpline listed in this slide, the general number, as well as the uterine helpline number. We have our support groups for women of African descent. We meet on every second Wednesday of the month. Our next meeting will be July 8th. And then we have our general uterine support group, which meets twice a month on Mondays. And our next date will be July 6th, and then again, July 20th. All right. We have an upcoming webinar on July 22nd, and it's what Black women need to know about endometrial cancer, and hosted by Dr. Kemi M. And we also have up on our website our past webinars, Uterine Endometrial Cancer 101 with Dr. Jason Wright, and just I believe it was at the end of May, we had a webinar with Dr. Jennifer Mueller on new treatment options for uterine cancer. Thank you.
Okay, well, before our final panelist, I'd like just to remind you, encourage you to submit questions via the question and answers feature at the bottom of our screen, and we will address as many questions as possible during our discussion. Please submit your questions in this key and answer features in the bottom of the screen, and we will add to the questions in the end. Now I invite, and thank you very much, Kithaka and Nefa-Tari, for your fantastic presentation. And I invite now Benda Kithaka for the last presentation. Please, Benda.
Thank you, Maurício, and thank you everyone for inviting us to this panel. My name is Benda Kithaka, I'm from Kenya. I am going to be presenting on cervical cancer specific and about Women4Cancer. Next, please. So a little bit about Women4Cancer. We were founded in 2012, coming from personal experiences with our family members who had either experienced cancer and had unfortunately passed on, or who had experienced cancer and was still living, and therefore we thought there was something that we could do about this. Our vision is a cervical cancer-free Kenya. And that's quite a big vision, because we are in a country that has cervical cancer as the leading cause of cancer deaths in women in Kenya. And we are in sub-Saharan Africa, which leads the world with cervical cancer incidence as well as mortality. And so it's quite a big vision for us. We anticipate that we're going to meet this vision and with our mission through working through policy advocacy that our government should be able to provide for services and provide for resources that can be utilized for cervical cancer advocacy and cervical cancer control and prevention. We also work through partnerships so that we can expand availability of services and resources towards cervical cancer control and management. Some of the networks that we are partners to include the AORTIC, African Organization for Cancer Research, then UICC. We are also members of the WECAN, that is the Women Empowerment Cancer Advocacy Network, that empowers women survivors as well as women organizations in sub-Saharan Africa for cancer advocacy. We also work through the Kenyan public, and for the longest time, our programs were funded by the Kenyan public, where we would do fundraising through crowdsourcing, events and activations to be able to get resources for cancer control in Kenya. At the same time, we have gotten into partnerships with various policymakers, including the County First Ladies Association, which has a membership of 47 counties, because these are the spouses of the county governors in Kenya, who then carry on the mantle for advocacy for resource mobilization in Kenya for cervical cancer prevention, as well as the Beyond Zero initiative, which is led by our First Lady, the National First Lady in Kenya, Her Excellency Margaret Kenyatta. We also have programs that go into treatment access and care access, where we're looking at removing barriers through patient navigation, so that our patients and women who are diagnosed can access the necessary treatment as well as the necessary care through our partners who provide psychosocial support. Next, please. If I can just briefly show you what our work revolves around. What you're seeing in the image there is one of our outreaches where we're surrounded by women who are seated with their children coming so that they can get screened. And this is in a community outreach. And behind me is the first ladies who came to this specific outreach. And you can see many of them have come. We call up the women, we have community mobilization, and then we have the women come. We have innovated that we have a mobile lab that can give our results in one day so that we're not losing them to follow up. At the same time, since 2012, we have screened over 8,000 women as Women4Cancer. And in 2017, we realized that we could not continue doing that by ourselves. It would take up to 30 years for us to be able to meet our mission of accelerating cervical cancer screening in Kenya. And therefore, we started working with various other partners through what we call the Stop Cervical Cancer Initiative. And STOP is an abbreviation for Screening, Treatment, Optimizing Diagnostics, and Prevention through the HPV vaccine. And through that, we were able last year to introduce the HPV vaccine in Kenya through working with the Ministry of Health so that we can be able to get our girls vaccinated as one of the preventative measures for cervical cancer. We also started engaging in 2017, 2018 in policy advocacy so that our government starts giving the necessary resources that would ensure that our work is continuous and is not inhibited by lack of resources. Through policy advocacy, we were able to start working in various technical working groups with the Ministry of Health, including the National Vaccines and Immunizations Program, as well as the National Cancer Control Program, where we sit in various technical working groups. At the same time, our secretariat pre-COVID had 7 permanent staff members and over 70 volunteers who are going to the community. Why this is relevant is because come COVID-19, I will be showing you what effect that has had on our ability to congregate, ability to mobilize, and ability to reach our constituents. We also started working in research through behavior change communications so that we're able to get our women to understand that it's a long haul. Cervical cancer takes time to develop, and also we need to change our behaviors towards adopting preventative measures as opposed to waiting until the signs and symptoms show up. Lastly, but not least, recognizing that through our community mobilization and community screenings, we would get women who are symptomatic or who have precancers that they didn't know were in their bodies. We have a navigation program that has for the longest time been able to get women who are diagnosed at the community level to get into the treatment system and to be followed up so that if they need any interventions, we remove all the barriers to treatment. Next, please. Now, I can tell you that what I've just presented about Women4Cancer, women with a passion to try and stop cervical cancer before it starts, is very common in the African setting, Pan-African setting. Through the networks that we work, we've seen similar incidences and similar instances where women say, or men say, let's start an organization to be able to mitigate the challenges that are systemic. Come COVID-19, and what you're seeing there on the screen is COVID in comparison with cancer. The data for COVID-19 is for last weekend, and the data for cancer is for GlobalCan 2018. Just to break it down a little, in Kenya, we have, we're talking about at least 134 new cases of cancer every single day diagnosed pre-COVID. And we have about 92 cases, 92 deaths caused by cancer in Kenya every single day. If I was to break down that a little bit to cervical cancer, we're talking about 9 women dying daily because of cervical cancer. Now with COVID, we have currently, if I was to read the data for today, as of yesterday, we're talking about, as of yesterday, 6190 cases and 140 deaths. If you look at that, against a background of 3,200 women dying annually, cervical cancer is taking away our women unnecessarily. And yet there is a lot of emphasis on COVID-19, and rightfully so, because this is a virus that we have sort of to make sure that we contain the community infections, contain the effects of COVID-19. We've seen the rest of the world and what the struggle has been, and in Kenya, our government has been very responsive. The critical thing to remember though, is that with COVID-19, there were quite a number of measures that affected the way we work in the country. For example, the government was very responsive, and by bringing in the measures for social distancing, for limiting movement, for lockdowns, we unfortunately ended up not having to be able to do our mobilizations at the community, not being able to talk to our girls about the vaccination, and even the stigma and the fear of infection, leading people not taking up the services. Next, please. Next, please. That's the one. And so, sorry, before that. And so what you're seeing there is the government response, where we even have guidelines on what people living with cancer should know. But right next to it is restricted public access to Kenyatta National Hospital, which is the only national referral hospital with comprehensive cancer care in Kenya. And now you can imagine, next please. If I can give you a live example of what we're going through currently, we have a woman 320 kilometers away, diagnosed at the facility with stage 2 cervical cancer. This woman needs to come to Nairobi for interventions, for treatments. For this woman to make it to Nairobi, to the Kenyatta National Hospital, she has to have a pass to be able to travel because Nairobi is on lockdown. She has to have the NHIF, which is the National Hospital Insurance Fund, so that her treatment can be able to be accessed easily. She also has to have a place to come and live. Most women, most people in the communities do not have relatives in Nairobi, so that's yet another barrier. Then they have to navigate the case for coming to the National Referral Hospital that's taking care of so many other patients. And right from the start, like if I can share a case that happened with us 3 weeks ago, a woman was referred, she came to Nairobi, lost 7 days to getting to navigate the hospital situation, got into the hospital, was put in an isolation ward to be able to check for her COVID-19. She had 7 days delay in getting the results. In those 7 days, she was then told she was COVID-free. Well, the results came negative. She was put in a ward, 7 more days because she needs blood transfusion. She also needs to be checked for her HB before she's put on radiotherapy. And after that, unfortunately, 1 day before she got into the radiotherapy treatment, we lost the woman. And so when we get calls now to navigate other women, our biggest fear is, will the system fail us as well? Will there be unnecessary delays? Will we get the woman to come to Nairobi and then get 21 delays in treatment? And what you're hearing from that is the cancer care has been affected, even though cancer care is considered an essential service in Kenya. We've had to change our treatment algorithms. We've also had system challenges where the government of Kenya, as much as we're trying, doesn't have all the procurement processes, and therefore delays in getting results, delays in getting PPEs to the healthcare workers, and therefore fear of infection for the healthcare worker as well as for our patients. At the organizational level, unfortunately, we've had to declare some redundancies because we could not contain a 7-person human resource capacity. And we also are not able to congregate with our 70+ volunteers. At the same time, some of our donors are in the US. We've had to rely on them for some of our programming in advocacy. And because of budget cuts in the organizations in the US, we've also been faced with budget cuts in Kenya. And in the community, I mentioned we do a lot of golf, a lot of community walks. Unfortunately, we've also not been able to start congregating for our community mobilization activities to get resources to continue with our work. That is the effect of COVID-19 in Kenya for us. Next, please. So at the background, as we think about COVID-19 and mention all the challenges that have been with COVID-19 and cancer care, let's also remember the pluses that have been highlighted. One of them being the response and strategies. Who would have thought it's possible to have a clinical trial in less than 6 weeks? Who would have thought it would be possible to have drugs being tested in less than 6 weeks? That's what COVID-19 has taught us. Who would have thought we would have billions of dollars allocated to advocacy for prevention of COVID-19, to community mobilization and community education for COVID-19. So cooperation and coordination, resource mobilization, leadership and communication. We have our ministry and our cabinet secretary giving an update every single day to the Kenyan public. What about cancer, which is taking so many more patients? We also have opportunities to learn from vaccines as prevention. If you think about it, for cervical cancer specific, which is preventable with a vaccine, this is a great opportunity to say, hang on a minute, we also have a vaccine that can prevent a cancer as we're looking for a vaccine that's going to prevent COVID-19. The use of rapid testing as a way of discovering COVID-19, again, yet another opportunity, because cervical cancer has HPV testing, and yet the kits are not easily available. The cost of the kits is prohibitive. Can we not advocate for that resource to be brought in for us as well? Inclusivity and trust building. We've seen a case scenario where the guards are working with the healthcare suppliers, with the procurement process, with governments and ministries. How can we bring this as well to the cancer space? And lastly, but not least, information, which is power. If we can think about coordinating our feedback, adaptation, and coordination. Next, please. So that image there, which shows a security guard taking the temperature of a layperson and people waiting patiently at the background, is quite a strong, powerful call to our advocacy. And my question to all of us is, how do we amplify the gains that have been brought in by COVID-19 to make sure that we can advocate for supplies, advocate for vital voices for prevention of cancer, and especially the preventable cancers. Amplify the vital actions towards control and management of cancer, and especially addressing the risk factors, the lifestyles, and ensure that this period for COVID-19 does not pass us by as an opportunity to reset our advocacy towards prevention of cancer and towards long-term gains in cancer control and management. I think I want to end it there, just to mention that as we are looking at what we are doing in the Kenyan space, I am joined on this call by various other survivors whom we're looking to climb Mount Kenya together as one of our advocacy platforms, even as we go into the COVID-19 situation. I'll talk about that later. Thank you. Thank you, Maurício.
Thank you very much, Benda. Fantastic work that you are doing. And I would like to congratulate all the panelists for the fantastic presentations. Well, we have now about 25 minutes maximum for question and answers and discussion. I'm sure we already have some from the, and I really encourage again to the people to send the questions. And I would like to open this discussion. There is a very good question from the audience. I would like to start with this question because I think it makes a very important view of what we have discussed. It's from Francis Hyde. At first, many countries shut down and reduced cancer treatment for women. But surely this is not a sustainable route. It's clear COVID-19 is to continue as a major health threat. What are the panel's views on how to ensure women can access cancer treatment safely? I'd like to start with I would like that Kemi M, if you could talk about this, and then we open for the other panelists. Please, Kemi, you can start with this question.
Sure. Yes, I think that was this has been the main challenge. I would say on the clinician side is balancing the risks of COVID-19 against the risks of not treating or delaying cancer treatment. I'm based in Seattle, Washington, so within the United States, we were essentially the first area that was affected by COVID-19, certainly have not been the most affected in terms of how it spread over the country, but had to start asking these questions earlier on than other areas. And I was really, I think we were aided by the guidance of the Society of Gynecologic Oncology as well with this. But what we recognize is that just as COVID-19 is lethal, cancer is also lethal. And so we really tried to focus on minimizing infection risk and minimizing the increased risk to our patients while still being able to provide the care that we knew that they needed. And so the way that we shifted was to do more telehealth and phone type of check-ins and visits so that there was still communication going, but really interrogating whether in-person meetings were necessary to follow up with how patients were doing. With regard to treatment, we kind of, in a lot of cancer practices, there are more urgent things, and then there are women who are on surveillance that are not having symptoms that are doing okay. So when we were able to move some of the surveillance patients and the patients that could be checked in via phone physically out of the clinic and out of the system, then that meant that when patients who needed to come in to be seen, who needed to come in for a pre-op, who needed their operation, they could come into a socially distanced setting. And so again, trying to really minimize their risk. We did not, and I can only speak to our local experience, did not have to stop important needed cancer surgeries for COVID-19, but I know that has happened in other areas simply because of the overwhelm of hospital resources. The way that I think that we continue to move forward is to, once there are resources available and once there are ventilators available and staff are able to be focused, or even some staff are able to maintain focus on cancer patients, I think we have to then do what we have always done, which is provide the exact care that is necessary, provide the highest quality care, and do the other mitigating factors of keeping the risks for those patients when they do have to come into the hospital as minimal as possible. So those are my initial thoughts on that question. And I think that it's an ongoing assessment, and the fact that we are aware and continually making the assessment is the key. I think where we go wrong is if we simply put cancer, quote unquote, on the back burner. And as you were saying earlier, wait till this is over when we don't know when this is going to end. I think our new job is to continually be doing these reassessment and risk assessments so that we bring the patients in who are needed. And I'll just add one more thing, which is that because we know that our cancer patients have this increased risk if they do get infected, we also have an extra burden in doing screening and risk management strategies for these patients. So I was part of an SGO webinar where we talked about how somebody coming in for chemotherapy needs really intensive symptom screening, needs an assessment of risk and all of that, because unfortunately there have been cases where women that was not known that they had the COVID infection, got chemotherapy and have passed away because of the infection. And so I think that that's another layer that we add on to our current treatment strategies now, which is that there's this extra level of assessment and care, and it does make sense to delay chemotherapy or to delay surgery if for the person themselves the infection is unknown or they need to be tested. These are the kind of things that we are pushing for, that we've implemented, but I think should be pushed for everywhere to try to balance these two threats that are happening simultaneously.
Thank you very much. Kitty, and would you like to make any comment about this? What I would like to ask you is, how can advocates and advocacy organizations work with clinicians and research more effectively in this during the pandemic? I ask you this because we know that as Kemi told us, we have more and more to work case by case, personalize the treatment and analyze. I'd like to know if the advocacy groups, they are helping, they are integrated with the clinician, is the decision which patient be treated, or this is only a decision of the institutions. I would like if the advocacies participate in this process.
To the best of my knowledge, in terms of individual cases, the webinars that I've been listened to with medical professionals is that every situation, like Dr. Dahl said, is individual, and that each patient needs to be in touch with their doctor, find out what's the best way to deal with their case. Can they afford to wait? Are the risks too high for for what needs to be done? So I think that part is very, very important. I think at SHARE, what we've tried to do is just give patients as much information as possible by having these special programs with doctors where they can ask questions on Facebook. We've had webinars, we've had lots of different programs where we involve the medical community and try to connect the patients in the medical community so that they can find out generally what the medical community is thinking. So that's probably the most important way that we've been involved with that.
I would like to ask you to Margie and Nefa, because at least here in Brazil, from the beginning, there was the big message: avoid go to the hospitals, stay at home all the time as much as possible. And now that the numbers are decreasing, the hospitals are almost empty, and the people is still afraid, fear to go to the hospital, to go for screening. I would like to view from the point of view of the patients, how we can manage it, how we can change this idea that women should come back to the hospitals, to the outpatients for screening, for treatment, because a lot of people is losing opportunities to be well treated. I'd like to ask you the point of view of the patient, how you can manage, how we can change this mind of the general population.
Margie here. My first thought is having that communication and knowing someone that you can talk to and trust. Because when you do that, then the person that might be afraid to go to the doctor, from my experiences, I would be really quick to tell them, don't be afraid to go. Talk to your doctor. If your doctor says, yes, I want you to come in, you need to trust that. Because the fear of going or not going, it just messes up the whole system of your body and what's going on. Early detection is the important part. So if something's going on and they can't see it over screen and we can't talk about it, through a Zoom conversation, and the doctor says, you need to go in, my words to them would be, obey your doctor, trust your doctor. Do you want me to go with you? Put your mask on, be smart, make sure you don't have a fever before you go, make sure that none of these symptoms are going on in your body. And you have to trust, and unfortunately as a patient, sometimes we haven't always had that trust. We haven't always had that our best interests were at hand. It's just like, oh, well, just do whatever you're told. Okay, well, you'll be fine. Oh, no, I really want you to come. Just the mixed messages sometimes that may come out when you're trying to communicate. So building trust is the most important thing. And during this, even more so. And I've heard stories from different patients and people that I know that have gone through some different things the last several years, that their doctors have reached out to them. How are you doing? How are you feeling? That whole, are you anxious? Because sometimes this can bring back, all this COVID stuff can bring back a little PTSD of, where you've been, if when you've gone through cancer, any other physical thing with your body. So you just have to really battle the fear and trust your doctor.
I really believe that Nefa would like to make some comments.
I totally agree with Margie just said. And then also, to take, I think it's great when you have that open communication with your oncologist as well. So, that also comes into play with trust and being able to, feel comfortable with actually going to have an in-person checkup with your oncologist.
Well, in your presentation, all of you already have talked about something about this, but I'd like to ask you, what service are you providing during the COVID-19 pandemic that you did not provide before the pandemic? What makes change in your daily activities? I'll share what you think you could make a difference in this moment of pandemic. Kitty or Benda would like to make some comments about this.
Yes, I can make some comments about this. So COVID-19 has brought quite a number of interesting perspectives to the kind of care that we do. One of the things that happened was the women we serve are from the communities where they have to debate between having food on the table and getting a screening for cervical cancer. And so if a woman is having to make a decision between screening versus getting the food on the table, she'll definitely make the food on the table choice. But now come COVID-19 and there is lockdown, they're not able to go out and get their own income. They're not able to engage in their own activities that would bring them the little money to be able to bring the food on the table. There is the double burden of someone has gone through a cancer diagnosis and they don't have food on the table. So we've ended up organizing to be able to do food drop-offs to patients and to caregivers and to families so that they can be able to continue getting nutrition during the COVID-19 situation. Another change has been the mental wellness. Now you can imagine someone is dealing with cancer, and then they have to think about treatment. They have to think about this social distancing, and regrettably, because of the social distancing issue, our country has quite a robust psychosocial support network, but regrettably, all patient support groups were shut down. They could not congregate physically. And when we do online meetings like this ones, we have limitations as to how many can come online because it requires data, it requires connectivity, and sometimes it requires a smartphone, which some of them do not have. And so we started a service where we're giving mental well-being through a WhatsApp chat, and so that people who have knowledge of counseling can be able to chat with the patients or the caregivers to be able to mitigate the mental wellness issue. The biggest challenge has actually been being able to get these women data bundles to be able to connect to also access that service. Another thing that has changed is provision of masks. Believe it or not, something as essential as a mask, at the moment the mask was introduced and said that everybody must mask up in public, the cost of the masks went up tremendously. And again, we're talking about a woman who is thinking about Do I get a mask or do I get food on the table? And that's yet another challenge. So we've had to do donations for masks, we've had to do donations for hand sanitizers, and congregate as a team to be able to say, what else can we do to support the patients, even as we look forward towards a situation where maybe it will open up for them to be able to move around some more. Yeah.
I could add one thing.
Okay.
I could add one thing. In addition to the special online resources and webinars and things like that, in our Latina Share community, where they've also been harder hit, the women that run that program have been reaching out to a lot of their constituents on the phone just to check in on them, make sure they're doing okay, find out if they have special needs. So there's been additional outreach on that front. And they've also developed some smaller groups, also using WhatsApp, so that they can all chat together. And there's also, because there's food insecurity, economic issues, and they've tried to help in those cases connect these women with resources that they need.
Well, continue. I'd like to ask to the patients representing, what we can feel that's really changing faster is the incorporation of telemedicine. At least here in Brazil, more and more, I think this is a process that was going, but with this pandemic, it will be faster, the implementation, and we are even changing the regulation. It's becoming, we are making it easy to make prescriptions online, everything. I'd like to ask Meg and Nefa about their experience with telemedicine, if you have already used it, and if you think it's a very important tool, it can replace in some way the personal meeting.
Well, for what I would say, my support groups are all through Zoom, and it kind of, well, we have women from all over the country that are a part of this group. So it doesn't really take away that connection. I think that, it's been going really well. We're still able to share with each other our stories and some of the difficulties and our emotions, as far as what we're going through with this disease or have gone through. And the many questions, we're still able to get that information out to the members of the support group.
Yes, and since working with ECANA, because we were all over too with our steering group members. I remember when Zoom first came out, someone that knows that I'm always the last to learn tech savvy said, "Do you know what Zoom is? I can show you, I can teach you." I said, "I've been doing Zoom for 2 years. I know what you're talking about." And I was like, so yes, and so with, like I shared earlier about our sanctuary survivor, once I wasn't, in the clubs teaching anymore, I finally had time to just make some videos. And when I shared it with a staff member, we were like, this is exactly what we're going to do. Let's just do it and see what happens. And we'll keep you posted, but so far so good. And I look forward to it. And I think that because of the pandemic and we've all been forced to communicate more this way, I think on one end, it's a good end. And I know a lot of friends too and I did have one friend who was fighting all kinds of stuff, and she was afraid to go to the doctor, and she enjoyed talking to her doctor on a Zoom conversation or Facebook. I mean, not Facebook, but FaceTime. She enjoyed that better. And then when it was time for her to go, I looked at her and she goes, I'm going in. She knew she had to go in. Now here she is, she was at that place where I have to go in, did all the protocols, went in, and she's fine. She recovered fine. They're not even sure if she actually had COVID or not because of all her symptoms, but just the example of someone that was hesitant on wanting to go into and how this really helped because she was able to build a better rapport with her doctor. She goes, I feel better now that I talk to my doctor more often. They're checking in on me once a week now, instead of, whenever you just go in and you don't feel good. And as for working with ECANA, we always have enjoyed this virtual experience. And then when we do get to see each other in person, it's really great because we feel like we already know each other.
Can I add
Very
something,
much.
Maurício?
Yes, please.
I just want to add also, I know you asked for the patient's perspective. I'll just add from the clinician perspective, I think that we should all recognize that what the pandemic is doing, I think it's highlighting the strengths and the challenges that were already present in the system. And so with the move to telemedicine, in the sense that when you had patient provider relationships that were strong and based on trust and mutual respect, those relationships survive telemedicine, and everybody can adapt. And I have patients who also, they don't have access to this kind of video conferencing, so now we're just on the phone. But because of the strength of the relationship before, we are able to move through, and they are able to trust me when I can get on the phone and say, okay, you have to come in. Like, I can't figure this out by talking to you, or I think that you're okay. But conversely, it's going to highlight the problems that we know already exist, especially among underserved communities, especially among Black women and Latinx women in the country, where they don't have ideal relationships with their cancer providers. They're not listened to, their symptoms are minimized. And so just like Benda was telling us about how it is amazing how we have marshaled resources to completely upend how we deliver care. I mean, I was still shocked when Congress passed a law in the United States to completely change how we do reimbursement for telemedicine. I mean, we have a government right now that can't do anything, but they were able to do that. And so I think that when we think about that kind of energy, I think we can put the same kind of energy into thinking about how do we establish trustful, meaningful, respectful relationships over telemedicine, over the phone with patients. Because if we can do that now, that means that we will have created lasting change when this is over. We'll have created a better quality patient experience from the clinician and the patient side when this is over. And so I challenge, if there are any clinicians listening or even patients listening, this is the time to really up-level our expectation of the quality of that relationship. Because one, we have to have it over telemedicine because we can't get around it now, but also it's going to be better for all of us moving forward. So I just wanted to add that.
And
Thank you very much. Yes, we have only more 2 minutes.
Yes.
You can talk in 30 seconds, please.
Thank you. If I can add to the question on telemedicine, regrettably, in the sub-Saharan Africa situation, telemedicine is not yet something that we can be able to claim to have very well developed because of the challenges I mentioned earlier. So we're looking at ways to learn through what it is that you're doing in the US, the UK, and other developed countries, so that we're able to accelerate this learning for our patients and for our clinicians. Because at the end of the day, we all want the same outcomes. We want the well-being of the patients with dignity and with outcomes that are positive impact. And so we would love to learn from you. Thank you.
Thank you very much. We are in the end of our fantastic meeting. I think it was, I would like really congratulate your 5 panelists that were fantastic, a very, very strong and outstanding presentation. And I think the last message is that, as you have, all of you has presented, the most important this moment is to have the hope that it will finish. This is temporary, it's not forever. In some moment, we don't know exactly when, but we expect that in the next months, we will finish this process. We'll have vaccines, and especially access for everybody to the vaccines. And I think the most important is to support the patients and to inform them what all you have seen, you have presented. The information and the support, the dignity of the women, this is the most important at this moment. I really congratulate you, your institution, for the outstanding, and IGCS for the initiative. I would like to thank all of you, and I ask the IGCS to close the session. Thank you very much.